Joining us from Imperial College London to discuss PSA threshold and salvage radiotherapy outcomes in prostate cancer, please welcome Dr. Hanya Irfan.
Okay. Assalamu alaikum and good morning. So, I'm Dr. Hanya, from a resident doctor in the UK, working in London. Today I'll be talking about the impact of PSA thresholds on salvage radiotherapy outcomes, and this will be a retrospective analysis of that. Sorry, I hope you can hear me a bit better there. So this is the landscape. After radical prostatectomy, PSA should be undetectable. When it rises, we know that disease remains either at the surgical bed or beyond. Salvage radiotherapy can cure these patients, and as the diagram shows, timing does determine that outcome. You treat early, the disease burden is low, you have a high chance of durable outcomes. You wait for imaging to show visible disease, the curative window may already have closed. This is the background. Mainly the Radicals trial, which published in The Lancet in 2020, established this current standard. Over 1,300 men were randomized to either immediate adjuvant radiotherapy or observation with early salvage, only if the PSA rose. At that time, the median PSA was 0.2 in their trial, and they found that there was no difference in biochemical progression, so early salvage was as effective as treating everyone up front and spared many men unnecessary toxicities. This established the current principle that we're now working with, so we can safely wait for early reoccurrence, but what happens when that early window is missed? Other key studies which shaped this hypothesis, so not only the Radicals trial, which I mentioned, but the SPORT trial that was published in The Lancet in 2022, showed that with their median PSA of 0.35, monotherapy was insufficient. You needed to add hormones and pelvic node radiation as well to improve outcomes. Other observational trials in the in-between zone showed that delaying salvage radiotherapy when PSA was more than 0.25 was associated with increased mortality, so not just biochemical failure. The question is, where exactly is that tipping point? So this is where our retrospective study comes into place. We looked at 117 men treated with salvage radiotherapy at a single UK centre in 2016. All had received uniform treatment, so 66 Gray in 33 fractions, intensity modulated radiotherapy to only the prostate bed. 15% had also received elective nodal radiation, but crucially no hormonal therapy was used. This is in line with the Radicals trial. We divided the patients by pre-treatment PSA, so 94 having a PSA of less than 0.3, and all the rest having a PSA of more than 0.3. This is a 4-to-1 ratio, which actually does reflect real-world practice. Most men are referred early, but a significant minority continue to present late. This is where I really want you to pay attention. So the curves tell the story. You can see above that panel A is biochemical progression. The blue line is group A, so less than 0.3 PSA, and the red is group B. The curves separate within months and stay separated, and by 2 years, group B falls below 40% with a p-value less than 0.001, so very significant. Panel B also shows overall survival. At 8 years, 86.5% were still alive in group A versus 53.9% in group B. That's a 32 percentage point difference. More than 1 in 3 of the patients in our group B had already died by the end point. But before we draw any further conclusions, it's worth noting, were these groups comparable? So this table does show baseline characteristics. Group B were our late presenters. They had more adverse pathology, understandably, higher rates of PT3 disease, 52 versus 28%, more Gleason scores above 7. So the imbalance is not surprising. Aggressive tumours do reoccur faster. So patients with high-grade disease burden are more likely to present with elevated PSA. And this is a real-world cohort, so it's not a randomized trial. However, it's still critical. The magnitude of our effect did show that pathological effects here would not explain the difference alone. We had a hazard ratio of more than 4.0, so that's larger than what Gleason upgrading or PT3 disease alone would produce in the literature. the PSA threshold does appear to capture something beyond tumour grade, likely total disease burden at the time of treatment, perhaps. It's worth noting that there are some limitations. Again, this is a retrospective single-centre trial. We did not perform a multivariable analysis, as I said, for Gleason score or pathological stage, and Group B did only contain 23 patients, limiting the statistical power and the precision of our survival estimates. But consider the strengths. This is an 8-year follow-up, long enough to capture mature overall survival and not just biochemical endpoints. A uniform radiotherapy protocol without confounding from routine hormones, just like in the Radicals trial, and despite the small numbers, a highly significant p-value of less than 0.001 for biochemical progression. So most importantly, our findings do align with these major trials that we've spoken about, the Radicals, Sports, and the Tiki observational trials. So just looking again at the framework that we have here, and synthesizing our data within the trial evidence, we do propose this practical framework. So below PSA of less than 0.2, this is your radical zone. Prostate bed radiotherapy alone, without hormones, still achieves excellent outcomes. No need for intensification. So anything above 0.3, this is your sport zone. So this is the population where the sport trial showed benefit from adding hormones or pelvic nodal radiation, and our data suggests that monotherapy here perhaps would not be sufficient, with an 8-year survival of only 54% for these patients. Between this is the tipping point, 0.2 to 0.3, and our data suggests this is where the window begins to close and urgent referral is needed. Don't necessarily wait for imaging like PSMA PET, and treat on biochemistry. The clinical imperative is here, so if PSA is rising, just treat on the biochemistry. A few take-home messages is that the PSA above 0.3 at salvage was associated with significantly worse biochemical control as well as overall survival. And the guidelines are shifting. NCNN now defines reoccurrence at 0.1, which is half the threshold normally put through with other guidelines. Modern assays can now detect disease far earlier than when the Radicals designed trial had come about. So it still remains, refer at the first PSA rise, don't necessarily wait for a number. And practically, if PSA is approaching 0.3, don't wait for the PSMA PET scan either. If PSA is already above 0.3, consider intensification as per the sport trial, AT plus pelvic nodes, and the rest of our data still is hypothesis generating. It's validation in larger cohorts that's really needed. These are my key references. And again, in summary, if early, then early salvage does work, delayed salvage fails, and the threshold does determine this outcome. Thank you so much. Thank you.
Thank you, Dr. Hanya.